again, thank you, Dr. Green, for your introduction. I'm happy to be here and really excited to be kicking things off and really diving a little deeper into some of the medications when it comes, uh, particularly in trauma. There's a lot of questions that come up, and I'm really trying to make sure we can answer a lot of those today. But I think it's gonna be really cool to kind of dive a little deeper into some of the data and answer some things that come up strictly with the medications. So objectives for today is just going to be to define RSI and its importance in trauma care, compare and contrast some sedative choices for RSI, and then evaluate some paralytic options and their considerations in trauma patients. And then we're going to assess some of the challenges and outcomes of RSI in different settings. This is something that Dr. Gibbs asked me to reach out about and look deeper into. So I'm happy to dive into this. So most of us understand very clearly about RSI within trauma. And again, it's going to be the rapid administration of an induction agent and neuromuscular blockade agent. And the goal is going to be to quickly, and I mean very quickly, secure an airway and minimize the aspiration risk and get these people to their outcome. From a historical standpoint, for any of you history gurus, again, it's introduced in 1970s from obstetrics anesthesia, and now it's going to be a standard in emergency medicine. The importance is gonna be just to improve oxygenation and ventilation, which is gonna be critically important for our injured patients and reduce the aspirational risk, as I mentioned before. Because unlike anywhere else, most of our patients are probably coming from a meal or, they're gonna be having full stomachs, unlike our people that are NPO for overnight and things of that nature. And then we're gonna be facilitating different types of airway management to secure this, and then we're gonna be preventing secondary brain injury, which is gonna be vital for traumatic brain injury patients. Some of the physiological challenges in our trauma patients is gonna be the fact that they're gonna be however the sickest they're gonna be in their hospitalization. They're gonna have shock, they're gonna have blood loss, there's gonna be a potential for airway compromise due to things like, facial fractures and neck hematomas. Again, we mentioned before, they have had a full stomach, so they're an increased aspiration risk. And at this point, they have raised intracranial pressure if they have TBIs. There's another component of cervical spine instability. So all of these things make trauma patients really unique. So again, just for background, just the pre-oxidation is going to be about 3 minutes of oxygen. It's going to be followed by sedation, paralysis, intubation, and then post-intubation management. So let's get a little deeper into the drugs. This is where I like to really dive a little deeper into some of these things. So let's go into a patient case. We'll go into a question, and then that will lead us into our presentation about the data in each of these drugs. So we have a 35-year-old male. He was involved in a high-speed motor vehicle collision. It has an obvious head trauma with a scalp laceration. The vital signs is GCS of 8, E2V2, M4. Blood pressure going to be 100 over 60, heart rate 120, and SpO2 is going to be 94% on 15-liter non-rebreather mass. The peoples were equal and reactive at the time. So the question, in trauma patients requiring RSI, does ketamine or etomidate provide better hemodynamic stability in neurological outcomes? And that's what drove me down a rabbit hole. And to be honest, there are so many studies and so much data out there that I can't combine it completely into this. That's a different presentation for a different time, just looking at this question. But I will do my best. So, an overview of ketamine is that it's going to be an NMDA receptor antagonist used for dissociative anesthesia at the doses that we're using at 1 to 2 mg per kg. Onset's going to be rather rapid at 45 to 60 seconds, and the duration can range from 10 to 20 minutes. The cool thing is, again, is that this dissociative anesthesia, this dissociative effect allows us to do some pretty unique things. So if you have a patient who is combative and fighting you and doing a whole lot, and you don't even have a time to get your equipment set up, this is a unique agent where we can give a portion or the total amount of ketamine to allow you to get that patient in a dissociative state, still breathing, still doing the things that we traditionally need them to do to prepare them for paralysis, and then ultimately placing that tube. And things to consider, and I'm going to be very cautious with this because I'm going to try to debunk it later on. Ketamine does a great job of maintaining or increasing blood pressure and heart rate. This can be very helpful in maintaining cardiovascular stability, but again, that's going to be dependent on a few things. It has some bronchodilation, which can be beneficial in airway disease, which is not really a primary concern for us in the trauma bay. But the thing that it does is preserves respiratory drive and airway reflexes. This is going to ensure a patient remains responsive and allow us to be able to do other procedures if it needs to happen right before, or we can really keep this patient to tolerate pre-oxygenation and get all our equipment set up. And lastly, something that it does pretty well is it has some analgesic properties as well. However, there are concerns and misconceptions, and I've heard this in many places I've been before, whether or not they're concern about ketamine increasing ICP. This is based off of some studies that was done back in the 80s and 90s that have been completely debunked. And I have a whole separate presentation just on this particular topic. But for the most part, again, everything that has been post 95 that looks at this, particularly in the patients that we see, have shown that ketamine does not increase ICP. And some data, if you look, actually says that it can reduce it. So I think we've kind of gotten over that fact that there's an ICP increase, and it's not something that bothers me at all, especially with the most recent data. Emergent reaction is another thing that gets people all riled up, particularly when I go upstairs and help out intubations on the unit. But it's going to be pretty rare in the fact that we're going to be intubating them and then providing them with propofol and sedating these patients that are stable. So you're not really see most of this happening. Contraindications, again, relative contraindication in severe hypertension, just knowing that you can increase the blood pressure even more than we can. And I always think of ketamine potentially increasing your systolic blood pressure in patients that have catecholamines about 20 to 25 millimeters of mercury. And it can increase your heart rate pretty dramatically, anywhere from I've seen ranges of 25 to 50 beats per minute increase in heart rate in patients that have catecholamines and they had no other severe cardiovascular disease. And then the potential for laryngospasms can occur at the lower doses. Some weird things happen when you start getting into those point ones and point threes and slamming that in. You can have some of those things occur, but again, the dosing that we're using, we haven't really seen most of that happen. And again, if they do, we're going to be intubating these patients. So there's a concept out there about ketamine induced hypotension. And some of the data out there has actually shown that in certain patients, ketamine can reduce blood pressure, which goes completely against what I just mentioned. But we have to try to dive deep and figure out what's causing it. So, on a mechanism level, this is going to be in patients that are catecholamine depleted. Most of these patients are going to be either those septic shock patients that's been down for quite a while, but for our trauma patients, always think of it this way. If your patient's bleeding a ton, they're super sick, their endogenous norepinephrine and epinephrine is on the floor. It's going to be not in the patient's body. And these patients persist in this catecholamine depleted state and they're trying to mount the response. If we catch them later on, they're going to be depleting all their catecholamine stores. And this is what can lead to a potential hypotension in critically ill patients. Something that is not talked about is the fact that this catecholamine surge or reuptake inhibition that ketamine causes is usually going to be overcoming the direct myocardial depressant effect that it has. So it does have a negative inotrope effect on cardiac muscle, but we don't really see it all the time because we have enough catecholamines in the body to overcome that. And this is due to the fact that it can decrease uh, SR calcium release and it can be more pronounced. And we're probably only going to see this in catecholamine depleted states. And you can have this biphasic cardiovascular response with some of the lower doses, again, being less than zero point 0.5, causing you to kind of surge that. And then the higher doses can have this myocardial depressant. And that's why we've seen some people kind of go to this lower dose of ketamine in their shock patients and continuing to maintain a fixed dosing or a higher dosing of their paralytic because of the fact that we can see this myocardial depressing effect. And looking at the patient factors again, I want to kind of re-emphasize what's causing this ketamine-induced hypotension is going to be just due to reduced catecholamine surges. They can also be hypovolemic because I always say their volume and their catecholamines are on the floor. What is it going to be? Their last drop of epinephrine is going to be back in the car accident that they had. So again, when they come here, they're not able to compensate due to all of this. And elderly patients may be more sensitive to myocardial depression. So they may also not have a lot of catecholamines at baseline compared to a younger person. So you reuptake inhibiting the receptor is not going to do much for these elderly patients. And I've mentioned it slightly earlier before, but considering lower doses in your high risk patients and being prepared for potential hypotension, monitoring closely and having vasopressors readily available. And most of these patients, if I can get them situated where we're giving blood, we're doing all these different things. If I can provide them exogenous catecholamines, they may not tank after. So that's a consideration to have. But I usually have vasopressors available, whether we're going to have push dose epi or push dose neo available. I have those things in the room, but I really want to have norepinephrine on the pump and just ready just in case. Again, preference being to blood and doing all those things, but I want to make sure that my drug is not going to cause an issue that it isn't really associated with the mechanism of the injury. So moving on to etomidate, our other agent. At CMC, this is going to be used when I pull up the data. We're using etomidate probably 10% of the time, to be honest. And the dosing that we can see is going to be zero point 0.3 mg per kg. Onset's going to be rather quick at 15 to 45 seconds with a very short duration of 3 to 12 minutes. The benefit of this, guys, is that it has minimal cardiovascular effects. It's going to be rather neutral. And what's pretty cool when I go and do work at other shops and see they are primarily using etomidate for all intubations. It's going to be their key thing. They usually say 20 of etomidate and 120 of sucks is going to be their go-to. At our shop at CMC, we're ketamine rock heavy. So this is something that's not going to be used as much. So that's why I bring this slide up just to let us know this is going to be another agent that we can use that's a GABA receptor agonist as well. The advantages in trauma is the fact that it does provide that hemodynamic stability. It ensures stable blood flow and pressure. It's going to be cerebral protective. It's going to reduce cerebral blood flow and decrease ICP, particularly at the doses that we use. Bigger doses as well can have anticonvulsant properties. But the cool thing is that at lower doses with etomidate, you can actually provoke seizures, and they can use this in brain mapping in epilepsy patients. But again, the dosing that we're using, we're not going to see this as much. Another component is that if we want a very quick neuro exam and we want this patient to wake up and be able to provide us with whether they're going to be blinking or following commands, it does have pretty rapid awakening. So you'll be able to get your tube in, have neurosurgery come down, assess the patient, knowing that something's not lingering around for another 10, 20 minutes. There are some concerns about this agent, particularly the adrenal suppression, and it can happen even after a single dose. This causes hypotension that doesn't necessarily happen right after, like ketamine does, because it has that direct myocardial effect. This is going to be a little later on. This is going to linger probably 4 to 6 hours after because it's going to be adrenal suppression. And that could again happen. Just the doses that we've used, we've looked at it in many different ways, whether it matters clinically and in mortality, but it does reduce the amount of cortisol that can be produced. And this is going to be consistent in the data. Another cool thing that happens with etomidate is it has this myoclonus doing induction. And it's going to be occurring in about anywhere from 10 to 80 patients. This is going to be based off of case series. So again, not able to find you a very tight range. I know 10 to 80 is a very wide range. But what happens is when you push the etomidate, you can see that patient kind of flex towards you. And a few things that happen when you're in a room with a ton of people and things going on, we can mistake this myoclonus as a seizure. We can have mistake this myoclonus as them posturing. So it's something to be aware of when if it's happening directly after pushing the drug. So usually we push etomidate and you're going to be pushing your paralytic agent, and it's going to happen right in that moment. And another thing is the fact is that it's going to be very viscous, so it burns. This is going to be worse than given 3%. This is going to be worse than given bicarb, D50, all those things. This is going to be super viscous and going to burn the vein when you give it. So a few things happen. You have this myoclonus happening during induction, but you're also going to have the fact that you're be pushing a very viscous product through their veins. There's a lot of data out there going back and forth whether it increases mortality in septic patients. This is not going to be our primary patient population in trauma, but again, some of those patients can become septic later on. And nausea and vomiting is not something that we really care about. We can suction those patients if they do vomit, but again, another thing that's going to be similar shared between etomidate and ketamine. So there's a ton of data out there. I'm gonna try to hit a few of them. But what I want to do is just kind of show you guys a host of the data. And for my trauma docs that are on, or the people who just say, "Hey, Jimmy, I don't care about you nerding out. Let's just jump straight to the chase and tell me what happened." Across the board, there's no major differences when it comes to mortality or SOFA scores. However, one of the studies we're going to look at post RSI hypotension, ketamine was associated with more, and another one showed that ketamine favored and hemodynamically unfavored. So we went back and forth, and I'm going to try to tap into a few studies that looked at whether this is going to be something that we should be concerned about. But before I do that, I want to make sure for completeness, I throw in some of the other agents, propofol and midazolam. I'm gonna be honest with you guys. I do not recommend this for most of our patients. Even though propofol can reduce ICP, the hypotension is real. Some studies saying that propofol can reduce your systolic blood pressure by 25%. Most of the patients that we have, again, their blood pressure of systolic of 100, I can't afford to drop it by 25. And it can be even more pronounced than that. I know this is something that may be preferred upstairs when you have a more controlled environment. You know more information about the patient. But I'm sure Dr. Gibbs and a few of the others that are on from EM can attest that you probably don't want to do this because it introduces more issues when you're trying to stabilize the patient. Midazolam, to be honest, guys, it doesn't sedate as well, and it doesn't work quick enough. It's not the ideal agent for us, and you're not gonna get what you expect from etomidate or ketamine. So, to be honest, I just don't recommend it at all. For completeness, I'm putting it there because I'm pretty sure anesthesia is gonna track me down and give me a yelling gap. But I don't prefer this in the trauma bag. These agents are too unpredictable, and it doesn't do what we need it to do um, during induction. So we're going to move forward to our paralytic agents. I forgot I put most of the studies in the back end of this. But our next patient is going to be a 50-year-old female with suspected surgical spine injury. She fell down the stairs. She had GCS of 7, blood pressure is 130/80, heart rate is going to be 90, SpO2 is 92% on 15 liters. And again, another obvious deformity of the cervical spine. So the question that came with this is in trauma patients undergoing RSI, how does succinylcholine rocuronium compare in terms of intubation conditions and complications? This is a topic that has been back and forth in the EM literature. I'm going to dive into a few different cases that you guys probably have seen some of before. I'm going to take a different approach when it comes to looking at one of these agents at the end with one study that I'm pretty sure you guys haven't thought about yet. So just for reminders, succinylcholine going to be 1.5 mg per kg, rather quick onset of 30 to 60 seconds with a short duration, and it's going to cause this prolonged depolarization of the motor end plates. Advantages is that it can be quick on, wears off pretty quickly, and have reliable paralysis. It's going to be pretty consistent and predictable results, especially with the fact that we can see it working with the fasciculations. It's going to be rather widely used and studied. I haven't been many places where this wasn't available, but some of my global health fellows has told me they don't have succinylcholine or rocuronium in certain parts of the country. So it's just here in CMC and most of our American EDs, we should have access to it. Some things to be concerned about or just to be aware of. You can have hyperkalemia with this agent, and particularly in conditions that also has hyperkalemia. That's what we're concerned about. Something that can look forward to in burns, crust injuries, and neuromuscular disorders. But this is traditionally after days, to be honest. So it's not something that we're going to see fresh from the scene, but it's something to be aware of. And if we know this patient has a baseline higher potassium level, we want to prevent that because succinylcholine can increase the potassium level by zero point 0.5 to 1. I've seen it happen. I've seen patients come in with a 5.3. We give them succinylcholine and immediately post intubation, they have peak T waves and they have a 6.3 potassium level. So something that can happen is something to be concerned about. Malignant hypothermia is the classic board's question to know if they have a history of it. Definitely want to get away from that. And this increase in ICP is super controversial. And we have to kind of figure out whether it's the drug or if it's everything else that we're doing that increase ICP. But I'm not on board to say that it does now, or if it do, I don't think it really matters as much clinically. Um, so it's something to consider. You can have prolonged paralysis in these patients that have acetylcholinesterase deficiency. That's the only case where you may see this lasting quite a while. Some of the other neurological conditions that we need to be concerned about, myasthenia gravis, things of those natures. So we want to make sure we can just be aware of that. And if they have any other past medical history that kind of puts us in this neuromuscular junction diseases, we want to avoid succinylcholine in these patients. Moving on to rock. Dosing is going to be 1 to 1.2 mg per kg. The onset's gonna be a little longer with 45 seconds to 90 seconds, and it's gonna be dose dependent. So if you give the LexiComp answer of zero point 0.6 mg per kg, it's gonna take forever for it to onset. And that's something that we know that Rocky Run is going to be dose dependent when it comes to its onset. But one thing that we don't consider is that the duration of 30 to 60 minutes is going to be based off young, healthy patients with the dosing that is closer to that zero point 0.6 mg per kg. I have a study that's going to talk about the higher range that we traditionally use and how long it can really last. So the advantage is that it's going to be relatively safe for almost everyone with any contraindications to succinylcholine. It's going to be only thing that you have to worry about is that it lasts quite a while, but that's gonna be reversible with Sugamidex or neostigmine if you have it available. And sometimes the longer duration can be beneficial in some scenarios. I like to get people to CT as heavily sedated as possible, but also them not moving so we can get the images that we need to for our trauma docs and all of our neurosurgery colleagues to do the best interventions post CT. Some things you have to consider in the moment, we don't think about the fact that, hey, this takes a lot longer for it to work. And sometimes I've seen our docs rush to their intubation because really they have to. And the patient is not fully paralyzed, and you don't have the window that you would like because you waited 10 seconds and went and intubated. You have to be aware of this slow onset compared to succinylcholine, and there's no fasciculations for you to be able to see that it's working. The longer duration may also be problematic if intubation fails. You may put yourself in a position where I've seen a 35-minute intubation process where you're going from person to person. And if you don't have everything set up in a facility that's going to be in a rural area, if you don't have a backup and it's just you intubating, you may put yourself in a bad odds if you can't reverse it pretty quickly or have any other things you can do to successfully get the airway. Higher doses can provide similar onset to succinylcholine, but you have to use that bigger dose. If you're using anything less than at anything less than 1 mg per kg, you're not going to match succinylcholine's onset. And the cost of reversal agents may be a factor in some settings. Most of us are not using Sugamidex and neostigmine outside of the OR, so it's something to be aware of. Is that, hey, this is something that's available, but it may be hard to get from pharmacy. I put it in our Omni cells at CMC, but it's something you have to be aware of, and I just want to be complete with that. So let's go ahead and dive into some of this data that we have here. The first question I wanted to answer is whether or not there's a difference in intubation conditions when looking at rocuronium versus succinylcholine. This one's going to be a Cochrane review that looked at 50 RCTs and about 4,000 patients. And what they did was they did two different things. They looked at doses of rocuronium at zero point 0.6 mg per kg versus succinylcholine. And then they looked at a subgroup analysis of rocuronium to 1.2 versus succinylcholine. Almost all of the data that you find with using doses less than 1.2 mg per kg of rocuronium has shown that succinylcholine is preferred. It provides better intubation conditions. And again, I think it's due to the fact that we don't wait long enough, the paralysis is not complete, and we're not getting the best bang for our buck when we're using those lower doses. But when looking at this RCT for results for high dose rocuronium, which for the most part, most of our level 1 trauma centers are using those bigger doses. There's no significant difference in excellent intubation conditions and clinically comparable intubation conditions. The only thing when I looked at some of these studies within it, very few of the studies actually used a high dose. So we're picking things out that is not this not exactly for this high dose. And most of these were elective surgeries. So this was not ED patients. This was not pre-hospital patients. So again, it's something I have to just disclose and make sure we understand. Another study was this Upchurch study, and it was comparing etomidate and ketamine for induction of RSI of trauma patients. So this was exactly what we was looking for. And I told you I actually mixed some of the studies in, but this was a retrospective analysis that looked at patients that were 18 years older, close to over 1,000 patients. So we looked at etomidate and we looked at ketamine. The average patient was Caucasian male, ranging anywhere from 37 to 40 years old. So our traditional patients. And we had a third of them that were TBI. Dosing was exactly how we use it at zero point 0.3 mg per kg for etomidate and 1.2 mg per kg for ketamine. What they found was no major difference in hospital mortality or any first pass success with intubation. Again, being almost exactly the same, 17% with etomidate, 20% with ketamine, and then it was 94% with both of the agents with first pass success. There was a lower incidence of hospital-acquired sepsis and vasopressor-free days with ketamine. So again, hospital-acquired sepsis was happening to 146 patients with etomidate and 99 patients with ketamine, giving you an odds ratio of 0.72, and free vasopressor days had an odds ratio of 0.74. So one study really showing that later on, these patients again had sepsis that were again traditionally trauma patients. So something to be aware of later on. Another study that gained a lot of popularity when it came to the hate of succinylcholine or RSI in TBI patients was this done by a fellow pharmacist, Sid Pantawala. And they looked at 233 TBI patients that were intubated in the ED. Their median age was 38 years old for SUCS and 53 years old for PROP. The average patient was again Caucasian male, and they were intubated with succinylcholine. 150 of those patients, and about 84 of those patients were intubated with ROC. What they found was that it was a higher rate of mortality with succinylcholine in the severe TBI group, and no major difference in mortality in patients within the mild to moderate group. And what this led to a craze of people saying that succinylcholine is going to be increasing mortality, and the reason behind that is going to be the increase in intracranial pressure. We've looked into this study multiple times, and it was a great study, but this is one of the few that showed a difference in mortality. And if any of my ICU docs are on board, it's almost impossible to find mortality differences across the board. So I think that they found this was intriguing. Lots of limitations. Again, as you see, the patient population looks very different. The people in the subgroups are a little sicker outside of just their traditional severe TBI category. But it's something that I wanted to bring out here because if someone tells you, hey, succinylcholine leads to worse outcomes in TBI patients, you should never use it. I want you to know where it came from. Again, the study looked at close to 240 patients, and they did show that again in that severe TBI group. Another thing that comes on quite often is that we just look at graphs like this and say, hey, our dosing of uh, succinylcholine and ROC leads to an onset of pretty much the same, and the duration is going to be 35 to 45 minutes. But at higher doses, it can have a quicker onset. But no one talks about the fact that Rocky Running lasts much longer than this, much longer than this. So I'll say I'm actually due to the fact that again, Rocky Road can last hours. And I wanted to figure out, okay, if it does that lead to any differences in outcomes? So would we do anything different if these patients wasn't intubated? So I pulled this study, again, a small study done at a trauma center out in Ohio by Sarah Hyland. And they looked at Sugamidex to facilitate neurological assessment of severe brain injured patients. And they just went and seen how it was an analysis and did it change any of their practices. It was a retrospective case series with a single arm co analysis of all brain injured patients receiving Sugamidex to facilitate neurological assessment during a 1-year program at a level 1 trauma center. The primary outcome was the quantitative impact of Sagamedex administration on neurosurgeon decision making. And I thought this was really, really cool because like, half of the time when we do stuff, we want to figure out, does it actually change anything? Does it move the needle? Would I do anything different if a drug was introduced or removed? And this study looked at that. Some of the secondary outcomes was change to their GCS and hemodynamic parameters after Sagamedex administration. Median dose that was used with Gamedex was 240 milligrams, and it ranged anywhere from 150 to 500. And the median time was 100, 101 minutes after the last dose, with a range anywhere from 42 to 231 minutes. So again, these patients were quote unquote reversed up to close to 4 hours after. This was some pretty intriguing clinical outcomes. So for their primary outcome, determination of the initial neurological assessment occurred in the ED. 67% of the scamming administration was associated with change to the neurological prognosis and plan, and 33% was associated with an increased certainty in the neurosurgeon's prognosis, affirming the previous plan. So when we reverse these patients who was able to see what was truly underneath it, and it changed something, again, almost two-thirds of the time. And all of the Sugamics administrations in the study population was deemed beneficial to neurosurgeon decision making, and 50% of all administration was associated with a change to the neurological prognosis and plan. So if we had 100 TBI patients and we use rocuronium like we traditionally do, up to 2 to 4 hours after get reversing those patients led to a change in half of them. So 100 of those patients had a different plan if we gave them rocuronium. So I want to kind of pause for a second to kind of understand the gratitude of that because we give a ton of rocuronium and most places use rocuronium now because it's the cool thing to do. But these agents can last hours and hours and hours after we traditionally think. And it actually matters to our neurosurgery colleagues when we reverse them because, again, they're actually changing their plan half of the time. And two-thirds of the time, it's associated with a change to the prognosis and or plan. So it's something to really consider the fact that our patients may still be paralyzed hours after. In all patients that had a GCS of 3T prior to the administration, the GCS actually increased in 67% of those that got administration, and they went up to close to eight, with 8 of those patients having being responders, quote unquote. And there was a significant increase in the median GCS after administration in all the populations from 3 to 8T. So it increased by 5 points in most of those patients. Again, that's enough to change the plan and to really give you a sure prognosis of what's going on. Now, I want to caveat a few cases that I've seen at our own shop here. This was a patient that I was involved in the care of, and it was a 65-year-old female that presented with a head bleed. And I'll just jump straight to the point here. On examination, the patient was intubated, sedated, and the ED pharmacist at bedside says patient received paralysis within the last hour or plan to reverse. Subjective exam limited by patient's condition. And showing us a continue of the clinical presentation. The patient was reversed with Sugamidex, and the patient neurological exam it's supposed to be improved, but approved, and the decision was made to proceed with EVD, and the patient was transported to the ICU for EVD with neurosurgery. The cool part was that that patient then went intervention didn't change, went to the OR, and this patient actually was discharged to a skilled nursing facility after 3 weeks of hospital care. And the last that I checked, again, was again not represented back to the hospital. Again, still shown as being alive right now. So cases like these can really be helpful when it comes to looking at our patient population and it's figuring out whether the drug actually matters. And we talked quite a bit about the name of this presentation was Does the Drugs Matter? It really does, and it depends on your patient, but you have to really consider all the factors associated with that. And that your patient, you may intubate them well with one agent, but you may not be able to get your neurological exam and to proceed with the best possible plan if they're still paralyzed or we don't have a tool or an assessment like a trainer four in the ED to assess those things. So, ton of other studies that I have here, just to show overall. Again, there were studies looking at whether Slux will be superior. Across the board, it's either no difference or it says succinylcholine is going to be superior, and that's going to be if they don't dose it accordingly. So when you look at first pass success, intubation conditions, all these things are we looking at whether or not these agents can be dosed appropriately. But when they do, you have to understand the back end of that as well. And I think I've kind of belabored this point quite a bit. You have to dose the agents accordingly. So the slugs are going to have a rapid onset of 30 to 60 seconds. You have to use high dose rocuronium, and you everything can be matter based off your patient, the age, comorbidities, indications, and then figuring out the setting of where you're going to be intubating them, and what's going to be the anticipated intubation difficulty, and whether or not you have reversal agents available. But both of these agents are great. They provide excellent conditions, but it really just have to depend on your patient and be prepared for a fair intubation with either agent. Something that came up, and I would say it's not heavily based on the medications, but a few of the docs that I spoke to before this presentation wanted me to look into some of this data and present that. So I will be honest and say I'm not an expert when it comes to this part of it, but if it matters whether the patient gets intubated pre-hospital versus the ED versus some of the other areas was a pretty intriguing topic, and I wanted to kind of dive and provide you guys with some of the data behind that as well. So in traditional fashion, we have a 40-year-old male with a crushing chest injury from a industrial accident. Initially, the GCS was 15, but en route, the patient became agitated and confused. Respiratory rate increased to 35, and SpO2 dropped to 88%. The EMS considered pre-hospital RSI versus rapid transport. So the question with this is, how do the outcomes of RSI and trauma patients differ between the different settings, whether it's pre-hospital, ED, or the OR setting? So from a pre-hospital standpoint, there are some advantages, especially when I reached out to different pre-hospital groups. Early definitive airway management is going to be great. Is a potential to prevent hypoxia and hypercapnia. However, there are some challenges associated with limited resources and assistance. And I know some of my pre-hospital people on board, your resources going to be differ across the state. And what you're able to do, not everyone can do. And I think the data is going to kind of point to that. And there may be some environmental factors like lighting and positioning, and provider experience is going to be variable across the board. The ED perspective, there are some advantages like a more controlled environment in pre-hospital and access to additional personnel and equipment and the ability to reassess and prepare more thoroughly. However, when those patients get to the ED and they're very sick, there's a time pressure in those critically ill patients, and multiple simultaneous resuscitations are going on. It may limit having the most experienced person in the room to do the intubation, especially when we're in these mass casualty like scenarios where we're spread thin. Places like CMC is going to be good, but smaller EDs that don't necessarily have a ton of the experienced personnel across the board may not have all the resources needed to provide the best scenario. And the OR is going to be the most controlled environment and provide a full range of airway equipment and anesthesia expertise are readily available. However, there can be some delays to definitive airway management, and patient deterioration during transport can be an issue. So you can talk to someone and your patient just crumps in the elevator, and you have to, a whole different setup. So I looked at this study that was a pre-hospital study that looked at intubation and whether it improved outcomes in patients with TBI. And it was a prospective RCT, looked at about 312 patients with severe TBI having a GCS of less than 9. And they compared the pre-hospital RSI compared to the hospital RSI. And they looked at extended Glasgow outcome scale at 6 months. And what they showed was that there's favorable outcomes at 51% in the pre-hospital RSI compared to 39% of the hospital intubations with a relative risk of 1.8. There was some limitations to this being a single-centered EMS system with well-trained paramedics, which may not necessarily be generalizable to all patients in all environments. But I think this was a cool study to look at what our pre-hospital colleagues can do, and looking at medic and just looking at our air team, again, they can provide great care and some data actually support it, especially if we have rigorous training and we're making sure that, again, we have expertise when it comes to those intubations. Looked at a few other studies, and again, this is not my expertise, so I don't want to drive too deep into that. But is all over the place when it came to the outcomes. So we had pre-hospital being superior, Pre-hospital would be inferior, no difference. It was going to be expertise dependent. And then we're looking at some of the other ones, looking at patients, again, it trends toward pre-hospital being superior or no different. So again, the data's all over the board when looking at this, but I can't really dive deep into this because again, it's not my expertise. And some of the pre-hospital folks and docs can really comment on some of these if they wanted to. So looking at this, recommendations for RSI is going to be based on the clinical setting. And I reached out to a few of my docs and it said it's going to really be dependent. So consider your transport times over 10 minutes and cannot maintain airway if you have adequate training and equipment and use simplified protocols. The ED perspective is going to be standard of care for most trauma RSIs and utilizing a team-based approach, but have difficult airway equipment immediately available. And then for the OR, again, definitely out of my ballpark here, it's going to be preferred for anticipated difficult airways if patient is stable long enough for transport and considering awake techniques in select cases. So just to summarize a lot of this, the choice of your induction agent, you're gonna have ketamine is gonna be good for some of your hypotensive patients, but again, only if they have catecholamines. Etomidate is gonna be suitable for almost everyone, whether it's trauma or not. From a paralytic standpoint, succinylcholine can be faster onset and shorter duration, and then rocuronium can be an alternative when patients have a contraindication of succinylcholine, or if you feel that rocuronium is gonna be the best agent if you're using a high dose. And then the setting in pre-hospital RSI is beneficial with experienced providers, and the E remains the most common setting for trauma RSI. Tons of different stuff to look at that I want to dive into. But again, it's not my expertise. So I just decided to put a slide here, things that I would like to discuss, whether you're using video laryngoscopy versus direct in trauma patients, ultrasound and guiding tube placement, the optimal oxygenation strategies, development of different induction agents, and refining hospital protocols. That's from an RSI perspective. So again, it's things I want to dive into, but I don't want to uh, belabor the point, and I know I'm going to get run short on time, so I wanted to delay that. So to wrap a lot of this up, again, RSI remains a critical skill in trauma care. Individualized approach is going to be needed for most of our patients, and staying updated on the evidence and guidelines is going to be key. And to put all this together, lots of data here. This is just a summary of from when you see a patient all the way to when we intubate them with our 7Ps, but I don't want to go deep into that. Special considerations within trauma, again, thinking about your cervical spinal immobility, full stomach, burn patient, pregnant, and elderly, again, they all have their different things to consider. And take home messages. RSI remains the gold standard for emergency airway management in trauma. The choice of medication can be tailored to your patient. Prepare for anything to happen and have protocols put in place. Stay updated on literature, regular training is going to be great, and always have a backup plan for failed intubation. So, what would Jimmy do? If I had to choose my RSI meds based on the patient condition, if their hemodynamic is stable, I'm gonna do ketamine sucks. Fast onset, short duration, kind of maintain hemodynamics. I'm able to do a lot with those patients from a post-intubation sedation standpoint and accurately assess them, and it really helps out quite a bit. If they're unstable, I'm actually going to switch over to atomic rock, which is really the opposite of what we traditionally do. But for our unstable patients, I think across the board, I have more comfort and knowing that my etomidate is not going to drop my patient initially. And when it comes to sepsis and things of that nature, I can give steroids. I can do a lot more things for that delayed hypotension that can come from the adrenal suppression. And high dose rocuronium is going to be great as well because again, I can have that rapid onset without any of the risk. And in an unstable patient, I can't talk to them. I can't get information. I don't want to think about those things. And for TBI patients, I'm a ketamine rock person. Uh, I don't believe ketamine increases ICP, and it may actually be neuroprotective and prevent against seizures and a few other things. And rock kind of avoids this succinylcholine's transient increase in ICP. And again, if we're going to go based off some of that data, even if it's weak, I want to put my patient in the best possible position, knowing that I'm probably going to have to reverse that patient later on if they need to get assessed by neurosurgery, or just make sure everyone's aware that this patient is still paralyzed up to 4 hours later. So lots of me talking. I tried to get done a little quicker so I can answer any questions and have a lot more conversation. Again, the data is going to be out there, a lot more stuff that I want to talk about. But again, I want to save on time as well. So please ask any questions or give any comments, and I'm willing to take anything.
Thank you, Jimmy. This was a great talk. We're using a webinar feature for the first time as opposed to a regular Teams meeting, so hopefully the questions will work out fine. If you for some reason you can't ask your question, just type it in the chat and I'll read it off. I see Dr. Gibbs with his hand raised. Dr. Gibbs? Actually, I see that I need to allow you to have your mic. I'll let you have your mic now. Can you try unmuting, Dr. Gibbs?
Now?
I can hear you now. Great. Go ahead.
Excellent. So, Jimmy, great talk. Really enjoyed it. Can you go back to your summary slide, the what Jimmy would do slide? Because I think that really captures nicely what it is that we can have some conclusions around. If you can project that slide again, because that really did a great job of. So, and I agree with 85% of what's here. Maybe we can talk about some other things. So, trauma room, it's hard, right? The patients are sick. If we're intubating them, by definition, they're unstable. And what I worry about the most is your bottom box, which is TBI patients. They have the most to lose. If they get hypotensive, their outcomes are terrible. So I like to think about protecting the brain as my prime directive if I'm in the ED. And I'll go from the don't do this, please, and then we'll move into your ideas. I think you pointed it out nicely. In my opinion, in the trauma room or an acutely injured patient, whether it be in the back of a helicopter or an ambulance, or even early in the OR, I would say that midazolam and propofol come off the table completely. We know that the incidence of post-intubation hypotension with those two drugs is unacceptably high. So I would say if I'm there, I will actually use the word never. I will never give midazolam nor propofol for an intubation in an ED trauma patient. And then I'm also not going to give fentanyl. Fentanyl, there was this belief that fentanyl could blunt the ICP response to laryngoscopy, but we also know that it causes hypotension. So I would say just take that off the table and stop thinking about it, which leaves you with really two fundamental discussions: is what is your induction agent going to be, and what is your paralytic going to be? And I think there we'll talk about the paralytics first. In my opinion, the most important thing with sucks and rock is to make sure you use enough. And we tend to underestimate the dose, the weight of our patients. So I would say if you gave me 1.5 of sucks at least, and at least 1.2 of rocuronium, you're probably going to be fine with either one. I don't think it makes a whole lot of difference. Where you get into trouble is when you underdose it. And you said very well, do not underdose succinylcholine or rock, because you'll have poor intubating conditions. I think I would probably maybe offer a different idea for traumatic brain injury. I actually like succinylcholine in traumatic brain injury, because then I can do a neurological examination 20 minutes from now or 15 minutes from now. I'm not going to be able to do that with rock. And I think there's good data that the fasciculations from succinylcholine are clinically inconsequential, and they're not going to cause a rise in ICP that will provoke any change in outcome. And then with regards to etomidate and ketamine, I like your stable versus unstable case. And I would just say there, be very, very careful, because sometimes you're fooled by the patient's vital signs. And if they have an abnormal shock index, which means heart rate over blood pressure of greater than 0.8, I will preferentially choose etomidate in all of those cases, because we know that in the patient who's compromised, as you stated, the incidence of post-intubation hypotension is unacceptably high. And frankly, I can't take out an epidural. I don't know how to do that. But my job in the trauma room is to not ever, if I can, let the patient become hypotensive. Last comment, then I'll be done. And I think now we also know better about vasopressor support in the trauma room, which traditionally has been felt to be inappropriate because it can mask under resuscitation with resuscitation, transfusion, et cetera. I would say do both, resuscitate like crazy now with whole blood, and you can bridge the patient through the intubation with vasopressors if you need to. And then once they've been on positive pressure ventilation for a while, you can back off the norepinephrine. And what I like to say is make it the most boring intubation of the week, because again, our prime directive is not to permit them to be hypotensive. So I would say I agree by and large with the vast majority of what you presented. I don't worry too much about sucks versus rock. And lastly, if they're compromised, I'm going to choose etomidate preferentially. Great, really great job. And thanks for sharing all this with us today.
Thank you.
Thank you, Dr. Gibbs. Any other questions from the audience? Jimmy, while we're waiting, Dr. Gibbs kind of brought this up. A frequent occurrence that we see in the ED is our pre-hospital partners having to redose their sedatives or their paralytics just prior to arrival at the ED, which can impact the neuro exam. That's usually done because the last meds, of course, are wearing off and the patient is starting to move around. Do you have any recommendations on how to best meet both the safety needs of EMS with a patient who's now moving around and might be becoming increasingly agitated, along with the comfort and safety of the patient, but then also the need for a good neuro exam that's not altered by those medications?
Yeah, this is something that comes up quite a bit. And the first thing I would say is try to optimize what you have in your protocols for sedation. Sometimes I see flight team doesn't have it as much, but my ground crew are not using as much ketamine to get them through. And I haven't been able to lay eyes on the actual protocols, what you guys are allowed to do for sedation of intubated patients, but trying to optimize what you can from a sedation standpoint, while of course making sure the patient is hemodynamically stable. But I think if you have to paralyze them, again, rock is going to be the agent you can go with, because double dosing of your succinylcholine actually has a paradoxical effect where you can actually have a longer duration of paralysis, and you can have a secondary block phenomenon that makes you more likely become bradycardic. So that's another discussion. But if you're using rock, that should be a conversation that everyone knows when you walk out the room. The patient has to be safe. The patient has to get transported, and we want to make sure that we get here appropriately. I can reverse them if I need a neuro exam. Not something that I want to do. Probably not something that pharmacy wants me to do because it costs a little bit more. But I think if we know what when the last time the patient was dosed with rocuronium, it helps all of us out. And if you don't have to paralyze them and you can adequately sedate them, if you have the blood pressure room, do that to the best of your ability. But I know it's very challenging, and I've done some ride-alongs, and I've seen how crazy it can be. One wrong turn, it can be bad for the patient. So again, optimize whatever you have. Make sure you're maintaining blood pressure. If you have to paralyze them, that should be something that the nurse, the trauma team, the ED physician, if you have a pharmacist, all of them should know before you walk out the room, because we can do something about it. We can make sure the patient is adequate for neuro assessment and get to and from CT safely. But we want to make sure, again, that everyone knows that patient is still paralyzed, and they can be paralyzed up to, again, 4 hours.
Wonderful, thank you. And a follow-up question from earlier. Is there one particular medication that you see the most complications with, or you wish just wasn't used?
I think if you're looking at the agents like propofol, midazolam, I think we kind of put those out. For the most part, I can't say that one agent caused more issues than the other. I can tell you that it accommodates the boring drug, and you have less issues across the board up front. Now, my ICU docs that are on, I don't know if they're seeing that increase in sepsis like I've seen in that one study. So again, if there is one agent that we use a ton of, I think I see a lot of ketamine, whether or not the patient's stable or unstable. I think that are primarily focusing on those patients that are unstable and giving them etomidate, that could be more beneficial. But again, I can't say outside of propofol and midazolam, where as an agent, I just say, please don't use again. It just really depends on the case. Dr. Gibbs?
Yeah, and I would just add one other topic you referred to, Jimmy, that is worth just another mention is etomidate and adrenal suppression. So it is well known that etomidate causes adrenal suppression. In fact, etomidate is a drug that's been used to treat hyperadrenalism. It's also known that if you give one dose, you will affect adrenal cortisol production. However, there is good data, primarily based on it was a tele ICU study done in the state of Maine when I was there, where they looked at a large population of patients who got etomidate or another drug who were septic in the ICU, and there was no difference in mortality or any measurable outcomes. So while etomidate does blunt cortisol, even if given once, my advisement is to not worry about that. There's no evidence of clinical consequence from a single dose of etomidate that's ever been published. So I think, again, it's academically interesting to know, but it's not going to be consequential when you choose your drug. And I think you're far more likely to run into trouble if you choose a drug other than etomidate and the patient's blood pressure declines around the time of intubation. Thank you.
Great discussion, everybody. Thank you for it. Jimmy, anything in the last remarks before we close it out?
Oh, no, just thank you guys for having me on. This is a really intriguing conversation, and there's a lot deeper to get into. So if you guys want more, please just let me know. But super excited about the future. Happy to work with all of you guys, and I hope you guys have a good Tuesday.
Great. Thank you, Jimmy. Thank you, everybody, for joining us. Please be sure to fill out an evaluation. Be sure to join us also in October. Dr. Kendra Ham will be joining us looking at pediatric non-external trauma. And then in November, competition for Jimmy, our peds pharmacists are going to come in and talk about pediatric RSI. So be tuned in for more information. We hope you'll join us. Thank you.